رکورد شروع کنید من Okay. Hello everyone, welcome to the third session of How I Treat Neurological Disorders short courses. I am Dr. Marjan Yaghmai, Associate Professor of Medical Genetics at Research Institute of Hematology, Oncology, and Cell Therapy Research Institute at Shariati Hospital, Tehran University of Medical Sciences, TUMS. And I am head of the leading house of Iran and North America Academic Partnership at TUMS. The courses program is a progression to how I treat neurological disorder, and these courses planned by the leading house of Iran, North America Academic Partnership at TUMS in collaboration with Neurology Department of TUMS. In this program, our well-known international expert in the field will focus on one or more distinct aspects of a single disorder and offer diagnostic and therapeutic advice. How I treat neurological disorders are comprised of more than 10 sessions that weekly or bi-weekly will focus on various aspects of different disease diagnosis, treatment, patient education, and network development. We intend to provide our neurologists with an opportunity to access the latest update of neurological disease, and we have gathered the lead experts to share their knowledge and clinical experience in each session. We hope these interviews can lead to a better understanding of neurological disease treatment. I need to take a moment here and express my gratitude to Dr. Aram Zabeti, our invited speaker from the US, for his kind support and collaboration. If you wish to receive an international certificate of attendance for each session, you need to register by Appraise to Raise website that the link can be found on the chat box. Today's session is entitled How I Treat Multiple Sclerosis. I would also like to introduce our moderator, Professor Muhammad Ali Sahrayan, Professor of Neurology at Sina Hospital, Tehran University of Medical Sciences. Please feel free to ask your question in the chat box. Thank you all again for participation in our course, and please make sure to write your correct name, the one that you have registered with. And please try to keep the chat in English. I sincerely hope that you have an enjoyable academic experience today. Now let me welcome Dr. Zabeti to the stage and ask Dr. Sahrayan to introduce our speaker. Dr. Sahrayan, please.
Thank you very much, Dr. Yaghmai. It's really a pleasure and honor to be here and introduce Professor Aram Zabeti, one of our close friends, and I'm sure that all neurologists here know him very well. I welcome him, and before starting his introduction, I would very much like to thank him to accept our invitation from Tehran University of Medical Sciences to be with us in this afternoon in Tehran and morning in Cincinnati. So Professor Aram Zabeti, he's Associate Professor of Neurology and Head and Chair of Waddell MS Center. He graduated from MS from Medical Science in Tehran in 1999. He completed postdoctoral fellowship program at the University of Washington in 2008 and did neurology residency program at West Virginia University from 2008 to 2012. He did his MS Neuroimmunology Fellowship at Oregon Health and Science University in 2012 and 2013, and he is Director and Chair at Waddell Center of Multiple Sclerosis since 2013. He is also Director of MS Neuroimmunology Fellowship since 2018. Dr. Zabeti will present us how I treat multiple sclerosis, and I would very much like to thank him again for coming and thank all our colleagues who has participated to this meeting. Dr. Zabeti, please.
Thank you, Dr. Sahrayan, for kind introduction, and thank you, Dr. Yaghmai, for organizing this meeting and inviting me. I'm honored to be among you. Last time I was in Iran was back in 2017, miss you all, and I look forward to hopefully come back in Iran and hopefully see you in person. So with that, let me share my slides so we can get the program started. We're gonna have a very busy presentation. Let me see, make sure that you see my screen. All right, do you see my slides?
Yes, we can see your slides.
Excellent. So these are my disclosures, and today my objective is to first start talking about our current understanding about multiple sclerosis, the disease course, disease phenotype, what are the treatment goals, and how we monitor these treatment goals, and the strategy, different approaches that we can achieve those goals, basically. I'm going to talk about disease-modifying therapy, but
Excuse me, Dr. Zabeti, may I ask to use the slideshow?
okay, let me hold on a second. I thought that I did put it in this slide.
Okay. Yeah. It's the right button. Yeah.
How does it look now?
Oh, we cannot see the slides.
Okay.
May I share the slides?
I have multiple windows open. Maybe that's why. I'm going to try again.
No, we can see, Dr. Zabeti, your slides. But if it goes,
but when I go to the, let me move it to.
Yeah, that's good.
That's good. Thank you.
That's good. Thank you.
No problem. But I'm just trying to see if I go to the presentation mode, why it doesn't show up. Let me try again. Do you see it now or not again?
You can see it's not on a slideshow.
Okay. I don't know how to change that. So I click on the presentation mode. Maybe it take me to the different screen.
If you have opened several screens, please close all other presentation and then share only.
I'm going to stop sharing and try one more time.
Okay.
Oh, perfect. Thank you.
Okay.
No.
I'm so sorry about the technical problem. All right. So I was going to mention about instead of going specifically about one each of the disease-modifying therapy, which is going to take very, very long time, I'm going to mostly focus on the class of the disease-modifying therapy, maybe mention about a couple of them, but then mostly focusing on the mechanism of action and how they work as a class. And then at the end with the Q&A, we can certainly go back and talk about different disease-modifying therapy. I want to make sure that I have time to talk about some of the consideration about disease-modifying therapy, also talk about some of the challenges in treatments of MS, including a smoldering MS, which is bring a whole new generation of new disease-modifying therapy, including Bruton tyrosine kinase inhibitor, and also maybe a few words about the aggressive MS and stem cell therapy. And then I'm going to briefly talk about the symptom management and wellness in multiple sclerosis. So the categorization of the multiple sclerosis has been simplified over the course of last few years. So we mainly now categorize them in the relapsing form and the progressive form based on the disability accumulation. If the disability accumulation is based on the relapse, we put them in the category of the relapsing remitting. And of course, with the first relapse, we still call them clinically isolated syndrome. But keep in mind, this can be active or non-active. And I explained that what it means in a second, because even a patient, if it's their disability accumulate based on the gradual progression rather than relapses, then we call them progressive MS. Primary progressive MS patients are the one that their disability start early on in their disease course, and the secondary progressive are the group of relapsing remitting patients that after a few years, they still might relapse, but majority of their disability and symptoms accumulate and based on their gradual progression. And again, we categorize each of these progressive MS patients in active or non-active, active progressive, active not progressing. Basically, the idea is to reevaluate the patient every year to make that assessment that whether the disease has changed, whether this change was associated from the relapse or MRI activity, or it was a gradual progression. So that's the current phenotype of MS. So most of you might be familiar with this slide, but I want to one more time go over that because it's gonna help me to make my point. So the first attack of MS, that we call it clinically isolated syndrome, is the time that it comes to our attention. So patients have symptoms, come and see neurologists for that. But MRI's activity tells us that this disease starts a lot early on. As a matter of fact, even it becomes clinically symptomatic. We now use the radiologically isolated syndrome. These are the patients that they get their MRI for different reasons, and then they meet the MRI criteria for multiple sclerosis. So they don't have an actual clinic demyelinating events, but their MRI shows that the MRI activity happened maybe many years even before the first clinical symptoms. And this MRI activity, as you can see, frequently happen even in absence of the relapse. That's why we take advantage of the MRI as a monitoring tool, not only for diagnosis, but also to monitor efficacy of our disease-modifying therapy, because it's in the asymptomatic activity can be monitored by the MRI during the disease course. And then after several years, many of the relapsing remitting patients go to the secondary progressive stage, which is still, as I said, they might have a relapse, but majority of their disability accumulate gradually, and you see less disease activity during this period. Why this is important is because we think most of these relapses and MRI activity is a marker of the peripheral inflammation. And this peripheral inflammation happened early in the stages of the disease. And why is this important? Because most of the current disease-modifying therapy that we have doing a very good job of controlling this peripheral inflammation. And that's a golden time for us to react. But neurodegeneration and compartmentalized inflammation is a very different story. That's the part that I'm going to address more in the smoldering MS chapter or section of the talk, because when this immune system in the CNS continue to cause gradual neurodegeneration, this is start early stages of the disease, but we don't appreciate it because usually it's asymptomatic unless patients lose their brain reserve. And then that's the time we start noticing the disability progression. So our job is to act quickly to preserve the brain reserve, to control the inflammation in the earliest stages, because again, most of our current disease-modifying therapy working on the adaptive immune system, and we can effectively prevent a lot of the MRI activity and relapse activity in the earliest stages of the disease before we lose the brain reserve. This topography model developed by Dr. Stephen Kager from Mount Sinai helped me a lot to explain this to my resident fellows and our patients, that what is happening in their brain. So he used the analogy of the pool of water as a brain reserve. So this brain reserve make MS diagnosis actually a challenge, because many times this MS activity remain underdiagnosed or undiagnosed because they are in the subclinical level. So For example, you see the spike of this white spark that you see here are the it's a symbol for the MS activity, but depends on where in the brain they are happening. They might be asymptomatic. For example, in the brain hemisphere, when the attack happened, patient might not have symptoms. That's the time that we call them radiologically isolated syndrome. And then when the attack happened in the spinal cord or optic nerve, where the majority of the nerve cells is very compact and dense, so with a small attack, patients still might have symptoms. So that's the time that they come and see the doctor. We diagnose them with the clinically isolated syndrome when it's past the clinical threshold. And then in the relapsing remitting phase, patient continue to have attack there in different parts of the CNS. But then what happened in the secondary progressive stages of the disease, this brain reserve, we start losing the brain reserve. So the clinical threshold change over the time. So what happened is some of those scar or lesion that happened early stages of the disease that they were actually asymptomatic, now become symptomatic in secondary progressive stages of the disease. And again, even in the secondary progressive patient might have some new disease activity, but the key here is that the problem is neurodegeneration and loss of the brain reserve in this stage, which can associate with a lot of disability. In the early stages of the clinical trial, when we were designing we were focusing on the relapse activity, MRI activity, and disability progression as the outcome measure. But then we realized that in the short the duration of the clinical trial, we might not capture all the MS activity. And for example, if in that 2 or 3 years of the clinical trial, if patient doesn't have MRI activity, you might not see any disability progression, but then long-term cohorts shows that when you follow up some of these patients over the course of several years, they might start showing some disability progression with or without relapse or MRI activity. So eventually, after the discovery of the first monoclonal antibody in the trial and shows efficacy of the natalizumab, many of the researchers start looking at the more comprehensive goal for management of multiple sclerosis, and they come with this term of NEDA, stands for no evidence of disease activity. The first NEDA was defined in 2009 as no relapse, no disability progression, and no MRI activity. And then over the course of next few years, we keep adding to that goal. So since we have more and more effective therapy, we hope that we can control this disease in more details and more have a better control in the disease activity. So NEDA 4, we add brain volumetric or brain atrophy to that. For NEDA 5, we try to look into the neurofilament light change, and in NEDA 6, even cognitive impairment. So these are some of the aspirational goals in management of MS. Doesn't mean that we are there yet, but that is something that we are trying to move towards to that goal. So currently, even in the United States, most of us, we just still focusing on the relapse and MRI activity. Even disability assessment of the disability progression based on the EDSS is a challenge. It's time consuming. There are a lot of limitations with the EDSS. So we mainly monitor our MS disease activity and respond to treatment based on the relapse and MRI activity. But at least I want to mention that there is a lot more happening in MS, and relapse or MRI activity is the tip of the iceberg. There are serum biomarker, MRI, volumetric MRI for brain atrophy that in our center in University of Cincinnati, we start collecting those data since last year. But as of now, we're not making any clinical decision based on them. We just start collecting them longitudinally. Maybe over the course of next few years, we might change our treatment approach. But for now, most of our treatment approaches are based on the relapse and MRI activity as a sign of treatment response. So you probably heard about Rio or score or the modified Rio score that you score the patient treatment response based on the number of the MRI activity and number of the relapse, and depends on the number, you decide when to switch your treatment. But this is, of course, you have to put everything in your consideration, that how many more options you have, what medication patient fails. So it's a little bit complicated. Again, in the Q&A, we can certainly talk more about those decisions. And then regarding the MRI as a monitoring tool, I also want to mention that you always want to make sure that you get a baseline MRI. So of course, at the time of the diagnosis, you want to get the MRI of the neuroaxis, including brain, cervical, and thoracic spine, with and without contrast, because I want to remind you about the McDonald criteria now allow us to make a diagnosis of MS based on the only first demyelinating attack. So if you get an MRI and there is a simultaneous presence of the enhancing and non-enhancing lesion, you can make a diagnosis. That's why it's very important to have that first set of MRI done with and without contrast for early diagnosis. If you remember from that diagram, that early diagnosis, the result better outcome. We can control the inflammation, which is happening the most first few years of MS, and that MRI is very important to satisfy that dissemination in time. And even if your MRI doesn't show enhancing lesion, you know, based on the 2017 revision, you can do the lumbar puncture, and if there is a positive oligopolar band, you can use that oligopolar band as a surrogate for the dissemination in time. And again, you can start the treatment even with the one demyelinating event, as long as the MRI satisfies the dissemination in the space, you can switch, most of the time it does, then based on the positive oligopolar magnetic cancer. So that's about that the initial MRI. But for the new baseline, when you start the disease modifying therapy, this is something that sometimes forgotten. So we have to have we have to give disease modifying therapy between 3 to 6 months, depends on that mechanism of action of the drug, to become fully effective. But then that's the time we reset our clock, right? So we need to get the MRI, another MRI, to set the new baseline, to see how many lesion patient have, and then we repeat the first MRI a year after onset of the disease modifying therapy. So again, about 6 months later. After that, we do it every year to just monitor asymptomatic disease activity, which is much more frequent than the symptoms of MS or disability of the MS. So we really don't want to wait for those disability to happen. MRI is a useful tool to monitor disease activity before those disability happen. And of course, after several years of stability, you might skip a year, you might do less often MRI based on the patient, the disease modifying therapy or the stability. But one other thing that I was going to mention is about that, don't forget that we also might need the MRI done even with the clinical stability, because most of the new disease modifying therapy associated with the risk of PML, progressive multifocal local encephalopathy, which associated with a high mortality. And MRI is a useful tool to pick PML in the asymptomatic level, which associated with a better outcome. Of course, if you pick it up on the MRI, you can stop or change your disease modifying therapy. So disease modifying therapy has been, there has been an explosion of them in the market. There are so many of them. You can see the timeline from the 1993 to most recent one that developed. Some of them, they are injectable, oral medication, and a monoclonal antibody that considered as a highly effective therapy. But there is some controversy around some of them, that cladribine, for example, whether considered as a highly effective therapy or maybe intermediate effective therapy. But everybody, I think, agreed that monoclonal antibody generally considered as a highly effective therapy. Other oral therapies, including fumarate, and S1P modulator considered as intermediate disease-modifying therapy. And then teriflunomide or Aubagio considered as a lower efficacy, closer to the interferon and glatiramer acetate. However, I want to mention that teriflunomide actually in many clinical trials perform very well in controlling disability progression. But when we talk about effectiveness, we are mostly focusing on the inflammatory phase of the disease, the relapse and MRI activity, which is, with that regards, teriflunomide is more close to platform injectable DMTs. But how to start the disease-modifying therapy? The old model for treatment of MS was based on the escalation. Escalation means that we were using platform medication or injectable first, and then monitor this patient for respond to the treatment. And if it was not responding, then escalate to next higher efficacy drug, maybe later. But many of us now questioning that approach because we feel that if our treatments are preventive, is why we are waiting for that disability to happen and then escalate the treatment. So the other treatment approach would be starting with the highly effective therapy and then de-escalate it later. To answer that question, there are two large clinical trials, Treat MS and Deliver MS. At the University of Cincinnati, we are part of both. This trial is ongoing. We really don't have the answer to that question, but I can tell you that there are more and more of my colleagues are on board to start the treatment with the highly effective therapy. For Treat MS, we focus on the disability progression, and in the Deliver MS, our primary endpoint is the brain atrophy. So I can tell you again, since this is the title of this talk is how do I treat MS? Again, I can tell you a little bit about my personal experience. And like, as I said, we don't have the final scientific answer to that. But in my clinic, I encourage patients to start with a highly effective therapy. And one of the first questions that I get from the patients say, okay, my symptoms are not that bad. Some of the side effects of these highly effective therapies are scary. And the patient says that why I need to take that risk. And my answer to them for my patient is to I use analogy of the blood pressure medication. I said, when we talk about the preventive medicine, we don't want the disability to happen. For example, if you have blood pressure that is usually asymptomatic, you want to start treatment aggressively to treat to the target, not waiting for the blood pressure causing a stroke or heart attack and then start the treatment. And that's how I look at the MS right now. So we're just looking at the MRI and the relapses, but I feel that there is a lot more activity happening in MS that we're not capturing with our routine clinical practice. And I want to be as aggressive as possible. Of course, there are safety with concern with some of the newer drug or treatment, but I try with the help of my team to monitor the safety of the drug as close as possible. But again, still not everybody on board in that approach. But even if we are not on board on the early highly effective therapy, we should consider or at least think about prognostic factor that some of these patients comes with. So some of the poor prognostic factor in multiple sclerosis that might lead us to start that aggressive treatment early on at the time of the diagnosis is the age of onset. The older the patient start the MS, usually they are poor prognosis. The type of the symptoms they have, if it's motor in sphincter, it has associated with worse prognosis compared to optic neuritis or sensory symptoms, for example. Male patient, other ethnicity rather than Caucasian, usually they're associated with the worst MS outcome. The recovery from the last attack or other previous attack, if they don't have a good recovery, that's poor prognostic factor. If they have multiple MRI lesion, if they have T1 lesion in brain, if they have high burden of the spinal cord lesion, these are all poor prognostic factor. And especially if you can do other biomarker, including neurofilament, optical coherence tomography, they also might help to maybe understand if this patient is at high risk of having bad outcome. So maybe that leads us towards like a early aggressive treatment or starting the highly effective treatment early on. So now let's move on and talk about the disease-modifying therapy. And as I mentioned, I'm gonna just categorize them in different categories, and then not going through a lot of details because it's gonna take, if we wanna talk individually for each of these drugs, it's gonna take a lot of time. So immunomodulator are the class of the disease-modifying therapy that they transition or switch pro-inflammatory cells to the anti-inflammatory cells. And then we have cell trafficking agents that, such as S1P modulator, that trap the lymphocyte in the lymphoid tissue. Or for example, another agent is the natalizumab that preventing migration of the lymphocyte to the CNS. Another class of the drug are the anti-CD20 on B cell therapy. There's actually the fourth one that I'm going to talk to you about that too, but anti-CD20 become like a most popular treatments of the MS in United States. Other cell depleting agents are cladribine or alemtuzumab, which work on both B cell and T cell. But as you can see from this picture, majority of these treatment approaches are looking or working, targeting our adaptive immune cells, all these reactive immune cells in the periphery, which is actually lacking any target cells in the central nervous system, which a lot of the inflammation and the problem in the MS these days we realize that happen in the CNS. So we are not targeting those cells. So if I have a chance, I might be able to tell you a little bit about the next generation of the MS treatments that they are in the clinical trial, Bruton tyrosine kinase inhibitor that can actually work both in the adaptive immune cells as well as the microglia and innate immune cells that we hope that maybe offer a better control in multiple sclerosis. And again, if we have time, I can talk about a specific group of MS patients with the aggressive MS not responding to our current treatment that maybe autologous hematopoietic stem cell might be a treatment for them. Talking about the immunomodulator, we have multiple forms of the interferon and glatiramer acetate. Again, it's been around for so many years. I don't think we need to spend so much time about them. They were a great treatment at the time that they came to the market. It really changed the trajectory of the multiple sclerosis patient. It helped a lot back then, but now we realize that we have a lot of better options. As a matter of fact, last few years, almost all these clinical trials that we have for new treatment, they are comparing, they are not placebo controlled anymore. They use interferon or glatiramer acetate as a control group, and we have enough data to prove that the current treatments are more effective. But of course, MS is such a heterogeneous disease that if patient already is on this type of treatment and respond well, you really have enough long-term track record that you are sure that they're working for the patient and patient is happy they're taking their medication, you can certainly continue that. But the problem is that the early diagnosis, that's the time that we really don't know who will respond to what drug, and the chance of having breakthrough disease and disability progression on this class of the drug, unfortunately, is higher. So that's why we try to encourage our patient, the newly diagnosed patient, to maybe get on the highly effective therapy, at least in my practice. But patients that they are on these treatments and they're responding well, certainly they can continue. The other problem with the injectables is the adherence. Unfortunately, half of these patients after a year, they don't take their prescriptions as instructed. So that's another challenges with the injectable drug, that patient doesn't take them regularly and that's actually, of course, lower the efficacy of the drug if they don't take it. Then regarding the or some of the oral drug, teriflunomide is it's a metabolite of the leflunomide working on the lymphocyte de novo proliferation, and it's a once a day oral drug that associated with the hepatotoxicity based on the history from the leflunomide, and patient needs to be monitored for the liver enzyme on the monthly basis for the first 6 months. It's also category X for the teratogenicity. So patient that they choose this drug, they do want to make sure that both patient and their partner there are and effective contraception because of the teratogenicity. The other oral drug is the dimethyl fumarate. It's a twice-a-day oral drug that it targets the NRF2. It's a neuroprotective pathway that promote anti-inflammatory cells to the pro-inflammatory cells to the anti-inflammatory cells. This drug commonly associated with the flushing and the GI symptoms, and in order to improve the GI tolerability, the company came up with the newer formulation called droximel fumarate or Vumerity, and it got the FDA approval based on the biosimilarity. So basically, both dimethyl fumarate and droximel fumarate immediately after digestion, they convert to the monomethyl fumarate. So they're working very, very similarly with the same bioavailability with the seems based on the Evolve MS trial, a very short trial. It seems Vumerity has better GI tolerability. One other side effect of this class of the drug is the lymphopenia. So patient needs to be monitored for the absolute lymphocyte count. So in addition to the baseline CBC, DIF, and liver enzyme, they need to be monitored through the treatment, especially if their lymphocyte counts drop. One of the kind of cutoff for that is like around 500. Then they need to be monitored even on monthly basis to establish the trend. If they become chronically lymphopenic, there were a few cases of PML associated with this class of the drug that majority of them, they had the chronic lymphopenia. But if the patient tolerates well without lymphopenia, that's not as much a concern. So regarding the cell trafficking agent, so let's first talk about the S1P modulator. So there are 4 of them. Last one, ponesimod or Ponvory, recently removed from the target. The main mechanism of this drug is by binding to the S1P1 and trapping the lymphocyte in the lymphoid tissue, preventing this reactive lymphocyte to go to the bloodstream and attacking. But they have affinity to the other S1P receptor as well. S1P5 also present in the macroglia oligodendrocyte. So in the next slide, I can tell you a little bit of difference between them. So all of these 4 different S1P modulator, as I mentioned, the main mechanism of action of the drug is by binding to S1P1, by trapping or sequestrating the lymphocyte in the lymphoid tissue. But 2 of them, siponimod and ozanimod, also has high affinity to S1P5. S1P5 showed in the preclinical data, showed that they have some neuroprotective effect. It might offer some advantages in the efficacy, but more importantly, because they don't bond to the S1P3, they are associated with the less risk of bradycardia. So the first generation of the S1P1, fingolimod, was non-selective. It was bonding to almost all of the S1P receptors, including S1P3, which causing a lot of unwanted effect, including in the AV node, causing very significant bradycardia. And all these patients on fingolimod for the first dose of the fingolimod, they had to be monitored for 6 hours. Every hour they had to be monitored for the bradycardia heart rate, and then at the end of that 6 hours they had to get the EKG. So it was difficult a little bit to start a patient on this treatment. And again, if they were off the medication for a while, they had to restart and do that first observation. But thankfully, because the newer generation of S1P modulators are selective, they don't have as much bradycardia. Even through the S1P1, through the GERD channel, which is the potassium channel, they might have some bradycardia, but not that significant like a fingolimod. So they were able to, the new class of the S1P modulator, they're able to mitigate that risk of bradycardia by the titration dose. So all of them, they come with the titration dose that the patient can take it safely at home, except the patient, they have a major cardiac attack or heart attack or stroke in the last 6 months. It's contraindicated, or they have a high degree cardiac blood. If the patient have a history of them, or they have a minor cardiac issues, you can consult cardiology and still might consider a S1P modulator, but that's a class warning, and you want to be always to be mindful of this history for this patient. Some of the other side effects of this class of the drug is macular edema, and patient needs to be assessed at the baseline and when they are on this treatment, except ozanimod or Zeposia, that the risk of the macular edema was lower in this class. So it's only necessary if they have history of diabetes or uveitis. The other side effect is of this class of the drug is the S1P, as a S1P modulator, they're associated with the skin cancer. So a patient also needs to be monitored for the basal cell carcinoma, melanoma, also, which is important. So regarding another cell trafficking agent, which is natalizumab, is bound to the alpha-4 integrin molecule and prevent the migration of the T cell to the CNS. Very effective treatment. The first monoclonal antibody that shows high efficacy in disability progression, relapse, MRI activity, but the challenge was the PML. So at least in the United States, half of the patients are tested positive for JCV antibodies. So they were exposed at some point to this virus, and the risk of PML is high. If they are not exposed to the JCV, the risk is very low. It's 1 in 10,000, almost negligible. The one that they are tested positive, for the one that they are not exposed to any other chemotherapy medication before, the risk of PML remain slightly relatively low for the first 24 months or the first 2 years, unless if the titer is high. So we use the stratify assay in the United States with the inhibition. So I don't know if that's available in Iran or other part of the world, but that helps a lot. Having this index help us a lot to stratify the risk of PML for this patient. Some of them, they might choose to stay on the drug for at least 2 years, and then we change them to something else. The other approach is that extended interval. Based on the retrospective data that we have in the United States, there is called REMS program, that every single patient that they get Tysabri in any infusion center, all the data about the PML and JC virus status has been collected. So those data shows that if instead of giving the natalizumab every 4 weeks, if you give it in there like 5-6 weeks, the risk of PML significantly reduced. But of course, the concern was that whether it's effective or not. And then there was a trial called NOVA that shows that similar efficacy between whether it's given every 4 weeks or 6 weeks. In my practice, for the patient that they have positive JCV, since we have a lot of good other treatment options these days, I don't necessarily continue the Tysabri and switch them to the other class of the drug, but that's a extended interval dosing is a consideration. So let's move on to the cell depleting agent. So the most important class of the drug in this category are B cell therapy. So we have Off-label use rituximab for many years in management of MS, but the problem in the United States, we don't have a FDA approval for rituximab, so there is no standard dosing for that. There's a lot of different variation of the dosing interval and regimen for the rituximab. But the first class of the drug that received FDA approval was the ocrelizumab, mostly humanized IV infusion every 6 months, 600 milligram, and then the next one was ofatumumab, which is a sub-Q monthly injection. And the most recent FDA-approved drug in the anti-CD20 therapy is obletuximab or Briumvi, which has glycoengineering. I'm going to tell you about glycoengineering a little bit in the next slide, but before that, I want to draw your attention that the B-cell depletion in this different drug is exerted by the different mechanism. Antibody-dependent cellular cytotoxicity and complement-dependent cellular toxicity. In focusing on the antibody-dependent cellular toxicity, where the natural killer cell or effector cells supposed to come and eliminate kills the CD20 B cell. The challenges was some of the first generation of the anti-CD20. They have a sugar molecule that prevent the strong bonding to the FC receptor in the natural killer cell. With glycoengineering, this new molecule, obletuximab, they were overcome that challenge. So they removed that focus from the FC region, and providing a stronger affinity and bonding to the receptor in the natural killer cell, in hope that that provide more sustained and more effective B cell depletion. Again, as a class for this B cell therapy, so they all need to be monitored. Patient before starting the treatment, they need to be screened for the hepatitis B virus that they might, the B cell therapy can reactivate that. Long-term treatment with the B cell therapy also associated with the hypogammaglobulinemia. So it's better to monitor patient for that, have a baseline immunoglobulin and periodically monitor the immunoglobulin. Still, jury is out whether this hypogammaglobulinemia is associated with the increased risk of infection or not. But in my practice, I monitor that, and depends on the patient age or other comorbidities, I might consider switching the therapy. The other monoclonal antibody that work on the both B and T cells and eliminate them is anti-CD52, alemtuzumab or Lemtrada, which at least in the United States, is the use of this drug is more limited based on the label. FDA put it as a third line DMT, almost like as a last resort. I think, but in Europe and other part of the world, there are more usage of the Lemtrada. Cladribine is an oral antimetabolite or oral DMT that is antimetabolite, again targeted the lymphocyte, and that's also one of the newer disease-modifying therapy that in United States still there are different approaches in when to use cladribine. Most of my colleagues, they use cladribine as a they call it now exit strategy. So patient that we're going to talk about that how long we're going to continue disease modifying therapy, because there are patients that they get older, you really don't know whether they really need disease modifying therapy for the rest of their life or not. And then of course risk of disease modifying therapy increase with the elderly patients. So they use this class of the drug sometimes to just stop basically treatment. So they give these two courses, both Lemtrada and cladribine is given in the 2 years regimen, year 1 and year 2, in hope by resetting the immune system, they might not need maintenance therapy for several years. So that is some of the usage of this class of the drug. I'm going to also mention about use of this drug in pregnancy when we talk about the consideration. Some of the consideration in the disease-modifying therapy is about the switching the treatment. So there are different reasons to switch treatment: lack of efficacy or suboptimal response, safety or tolerability, cost or insurance problems, or many other reasons that you might need to switch their disease-modifying therapy. But there is no standard protocol to tell us what to do next. So there are multi-factors important to make that decision. That most importantly, mechanism of action of the drug. You generally don't want to use the same drug with the similar mechanism of action. You want to change the mechanism of action, but then changing the mechanism of action of the drug, you also have to consider drug-drug interaction, how long you want to wash out the medication, previous DMT before you start the next DMT. These are all, in my opinion, case by case. There is no standard protocol for that, because I can give you an example for my younger patient that there is a higher risk of having MS relapse, or they have a bad relapse, history of relapse. I don't wait too long for the washout, and I understand that there might be some risk of drug-drug interaction if I start the next disease-modifying therapy early. But in my opinion, managing the side effect sometimes it's easier than manage a bad relapse. But in contrast, then when you have an older patient, that the risk of the relapse might not be as high, and then you more worry about the side effect or toxicity of this disease-modifying therapy, you might decide to have a longer washout period, basically. Pregnancy also is a big challenge. Of course, many of the patients are in the childbearing age when they're diagnosed with MS. Copaxone is category B, interferon considered to be safe. Most of the other disease-modifying therapy are category C, except teriflunomide, which is completely contraindicated. So if we want to focus on the safety of the baby, of course we can wait the full 5 life and make sure that all the treatment is washed out from the system. But of course that poses a risk for the mother. So in my practice, I talk to my patient to come up with some strategy to balance this risk between the risk for the baby and risk for the mother relapse. One of the treatment approach that we take, me and many of my colleagues do these days, is the B-cell therapy. We think that the B-cell therapy probably provides a relatively easier transition during the pregnancy. So we think that our patient can start practicing for pregnancy about 3-4 months after the last B-cell infusion, for example, if they're on Ocrevus. And of course, pregnancy doesn't happen right away. And even if it happened, by that time, there are lower concentration of the circulating anti-CD20 in mother bloodstream. And even if there are some of them, based on the size of the molecule, we think that not many of this anti-CD20 is going to pass the placenta in the first trimester. So that's how we think that by that time, when the mother gets pregnant, hopefully then, of course, pregnancy hormones are very effective in preventing MS activity. So we think that provides some sort of like a smooth transition to the pregnancy. Some of the other colleagues use induction therapy, as I mentioned, Lemtrada or Cladribine is given in 2 courses, year 1 and year 2. And then after they're out of the system, the patient doesn't need to be on maintenance therapy. Many of these patients are stable for several years, and that's the time they can practice for pregnancy. Vaccination is another consideration in the disease-modifying therapy. So there are 2 things that in the vaccination we need to talk to the patient: safety of the vaccine and effectiveness of the vaccine. In regard to the safety, the general guideline is that no live or live attenuate vaccine with the disease-modifying therapy, because most of the current disease-modifying therapy, they can actually suppress the immune system to the level that the live virus can actually disseminate it and cause more problem. But then other vaccine that thankfully these days most of the vaccine are not live, so patient can take it. It's safe to take it. However, the challenge is that whether they are effective or not. So with some of the disease-modifying therapy, including immunomodulator, natalizumab, fumarate, we think they don't impact the response to the vaccine. So it still should be effective. And many of those vaccines has been actually studied in this treatment. The challenge are the B-cell therapy and S1P modulator that might lower the immune production, antibody production against the vaccine. So with that, again, it's a kind of risk and benefit discussion between the patient and the physician, that how important is that vaccine. If you want to make sure that the vaccine is fully effective, so of course we can stop or postpone the treatment and then get the full vaccination. And we always encourage the patient to get all the vaccination that they needed before starting those disease-modifying therapy. But of course, there are seasonal flu and other vaccine, COVID vaccine, that they need to get it through the treatment. So then we have to either hold the treatment, or if we feel that, no, again, if the risk of MS activity and damage from the MS is higher than that infection, we generally recommend to get that vaccine, especially if they are on the Ocrevus or some of those infusion therapy in the second half of the interval. So for example, if they're on Ocrevus, they get their infusion after 3 or 4 months. If the timing allow, they can get their vaccine. And again, keep in mind that this vaccine remain effective because we're not impacting T cell as much, but if we want to have a better response from the B cell, we can do it after 3 or 4 months after the last infusion, and maybe a couple of weeks before the next infusion, in hope that we get a better B cell response to the vaccine too. There are guidelines from the ANN. I think I'm running out of time, so I'm gonna go a little bit faster to make sure we cover a few other things. Stopping disease-modifying therapy, as I mentioned, most of the clinical trial is only for patients up to age of 55. We really don't know those disease-modifying therapy are effective or safe for older patients. So there is a study called DISCO-MS designed to look at the individual above 55 that they don't have a relapse for 5 years or an MRI activity in 3 years, to look at whether discontinuation was inferior to the continuation or not, and it could not reject that hypothesis basically, but it was favoring towards maybe discontinuation posed some increased risk of activity. The limitation of this study, as you can see, is that very, very low number, only 3 relapse happened in discontinuation group and 1 in the continuation disease-modifying therapy. MRI activity was more in the discontinuation, but did not meet the statistical significance in 2 years. This is an ongoing study, so we hope that maybe we get some guidance with the additional analysis in the future. Now I'm going to move to some of those challenging treatments in multiple sclerosis. I mentioned that although we did a good job, I think that we made a lot of progress in controlling the inflammatory phase of the disease present with the MRI activity and relapse. But in almost every clinical trial, we see group of relapsing patients that their disability progress in absence of the relapse. We call them PIRA, or progression independence of the relapse activity. In contrast to RA, which is a relapse associated worsening. So this study is actually OPERA study. It's one of the best treatment available for relapsing MS patient, Ocrevus, comparing the ocrelizumab to Rebif. And you can see Ocrevus did a good job of controlling the relapse-associated worsening compared to the Rebif. But when you look at the PIRA, unfortunately, not much different. So still, there's a relatively good number of Ocrevus patients that continue to progress in absence of any relapse, basically. So this is another study, expand study for siponimod, designed for the secondary progressive MS. But when the FDA looked at the result of the clinical trial, they saw that the effect of the drug was mostly driven by the MRI activity patient that they have multiple gadolinium enhancing lesion, or patient that they have multiple relapse in the past, or even younger patients. So that was the reason actually FDA changed the designation for this indication. They call it active secondary progressive. Active, again, defined by the MRI activity and relapse activity. It seems that all these drugs, including siponimod in this case, work a lot better for patients that they have active disease, relapse, or MRI activity. Again, looking at the adaptive immune system, peripheral inflammation. We're doing a good job in controlling them, but not targeting the CNS or compartmentalized inflammation. This meta-analysis by Dr. Sormani and her group, again, looking at some of the other progressive clinical trial, and then they saw that also some of them, they shows efficacy, but then when you remove the active group from those cohort, if you focus on the subgroup of not active, purely progressive MS patient, unfortunately, they failed to show efficacy. The most typical one was the Ocrevus. That's the only treatment that approved for the primary progressive in United States. When you compare to the other primary progressive clinical trial, you see generally they were younger and they had a lot more gadolinium enhancing lesion in the clinical trial. Again, going back that that's the group of patients that benefit from this type of treatment. I want to highlight that the smoldering MS is even more complex. We are not only we have to target and think about innate immune cells and the microglia in the central nervous system and role of them in the smoldering MS, the age of the patient, different comorbidities, the mitochondrial dysfunction, and there's so many other factors is important in the smoldering MS, but targeting the microglia and compartmentalized inflammation is the key. So again, on the left side of this slide, you see the neuroinflammatory phase of the disease that happened from the adaptive immune cells migrating from the periphery. And I think, as I mentioned, we did a good job with our current disease modifying therapy. We can have a relatively good control in this part of the disease. But when this inflammation become compartmentalized in the CNS. And again, I want to also mention that we still don't even know the theory of the MS, whether it starts inside out or outside in. We don't know what is happening in MS, but there are compartmentalized inflammation, including actually lymphoid tissue in the central system. There are lymphocytes
I think we missed our connection with Dr. The connection interrupted with Dr. Zabiti. Dr. Yaghmai, are you? Could you please send a message to Dr. Zabiti to reconnect again?
الو
سلام خانم دکتر.
سلام استاد، احوال شما خوبی؟
مثل اینکه کانکشن. I just informed the technical team and our colleague in order to contact Dr. Zabeti to have a connection again. So we will wait for a few seconds to see what will happen. To start. Another question, in decrease in brain reserve on progression without acute attack in patient on high efficacy drug, what is the next step? And Dr. Nahayati's question is, what is your approach in treatment of young under 40 years ambulatory progressive MS patient that is EDSS-5 without MRI activity and the treatment of first or second line DMD? Do you escalate their treatment? And the next question from Dr. Baghwanian is, what is the proper management of veering of phenomena in anti-CD20 therapies? So we are waiting still for Dr. Zabeti, and I will not try to answer the questions because I know that you may know, you want to know his opinion, and all of the people here are actually, they are experiencing multiple sclerosis. Okay, welcome back, Dr. Zabeti. I think your mic is mute. Could you please unmute your mic? Your microphone is mute.
Okay, I'm so
Yes.
sorry, Dr. Sahrayan and everyone for the technical problem. I apologize. So how much time do I have? Do I have like another 5-10 minutes? I'm sorry that it delay everything. If I have time, I can go and finish up in the last few slides. All right. I'm sorry, I can hear you now. All right.
Dr. Zabeti, we received a lot of questions in the chat box, so we have another 10 minutes to go for the presentation, and then take care of questions.
Okay, do you see my slide?
Yes, of course, yes.
I don't know at what point the call dropped, but I would just want to highlight the role of the innate immune cells or macrophages in the smoldering MS. So these macrophages is part of the pathology of the MS that for many years were not even in our radar, basically. So when the active lesion, the demyelination happened, there is a combination. Pathology shows us that in addition to adaptive immune cells and our lymphocyte, the microglia also changed from the hemostatic macroglia to the pathogenic macroglia, and this macroglia become part of the pathology of the MS. They actually migrate to the border of this demyelinating lesion and continue to bite on the myelin. Myelin is a heavily lipid material, but it also has iron. Interestingly, the technology in advanced MRI techniques can actually help us to see these lesions. So since this microglia in the rim of those lesions continue to digest and bind the myelin, we see rim-enhancing lesions. So these are iron, the position in the rim of this lesion that the susceptibility weighted images or GRE, any MRI techniques that is sensitive to the iron, we can start seeing these lesions. So pearl or paramagnetic rim lesion is now one of the biomarkers that we think that it helps us with this chronic active lesion. The other biomarker is the slow evolving lesion. So some of these T2 lesion, when you use advanced MRI technique, you understand that these are not stable. If you just look at this with your eye, you might not see the difference from year to year. But if you do advanced MRI technique and volumetric MRI, you can measure that these are slow evolving MRI lesion. Interestingly, this case actually was about the clinically isolated syndrome patient. This is a gentleman with the only one clinical attack. These are the patients that we, for many years, we were dismissing. They say, oh, what do you mean your symptoms is progressing? You're not having any new MRI lesion. You're not having a relapse. So you're fine. You're exaggerating. But now we pay more attention. We understand that this disease is really not in remission if we really pay more attention. So this brutin tyrosine kinase is a good target for us, for treatment target, that it both impact the adaptive immune cells, or B cells. In addition to that, we can also target microglia. This becomes such an interesting and hot topic for the treatment that almost all the MS companies now investing on that. We have 5 different BTKI in the clinical trial in different phases for relapsing MS, progressive MS, and we hope that in the next few months or few years, we're gonna see the result of those trial and hopefully show some positive result. So last few slides is about the aggressive MS. These are a group of MS patients that with the current FDA approved drug, they continue to break through with their clinical relapse or MRI activity. We, based on our meta-analysis on the previous clinical trial, we understand that the current disease-modifying therapy, oral and monoclonal antibodies, are doing a lot better than the interferon, which were not very different from placebo. If you look at the no evidence of activity, again, all this medication got approval based on the reduction in the annual relapse rate and all that. But if you look at the no evidence of disease activity, they are not very effective. But then there are still patients that in the FDA approved drug, they continue to have breakthrough disease activity. And we think maybe stem cell therapy might be a better option for them. And that's why we are interested about that. I want to highlight that there's a lot of misunderstanding and misperception from the different type of stem cell therapy. There are mesenchymal stem cell therapy and oligodendrocyte progenitor cell stem cell therapy, which the goal of those stem cell therapy is neuroprotection and neurorestoration. However, they are in the very early stages of the disease. The stem cell therapy that I'm interested in more talking to you today is about hematopoietic stem cell. Hematopoietic stem cell is basically resetting the immune system with the goal that not having more relapse or breakthrough disease activity in the future. They might have some effect on the neural repair, but majority of the goal of the treatment is stabilizing patient from not having more attack. And this is based on the multiple clinical trial that was done in the past with the different intensity. So one of the first trial, the protocol was from Dr. Burt. Dr. Burt using low intensity immunoablation. So it's actually more of the lymphoablation, not much even myeloablation. And the advantages of that is that doesn't have as much toxicity or side effect, but it's not much more effective than many other current treatment that we have. And then on the contrast, we have a Canadian protocol that is very intense. It's a high intensity and has a very high level of myeloablation, but then also, of course, that also associated with some risk of safety. So The intermediate intensity is the one that is more popular based on the HALT MS trial than it seems that have a good balance between the safety and efficacy. As I mentioned, one of the recent actually meta-analysis shows that again, some of these stem cell therapy not even too much different from ocrelizumab. This is one of the recently published meta-analysis, but again, depends on what protocol you're talking about and what patient selection you're doing. Patient selection is very, very important in the success of the stem cell therapy. Of course, if you're using a stem cell therapy for a patient that they don't have as much severe MS, of course, the result is not going to be different between ocrelizumab and stem cell therapy. Ocrelizumab already doing a very good job, or new treatments, all of the new treatments. But there are group of patients that they are very aggressive, their MS is very aggressive, and they break through on that. So in order to answer this question, still, of course, the debate there's a lot of debate about that, the safety and efficacy of a stem cell therapy. NIH now designed a phase 3 clinical trial. As you see, I'm the principal investigator for that trial to randomize this patient to best available therapy. We call it BAT arm, which is monoclonal antibody, and then half of patient randomized to the stem cell therapy. And then if the stem cell therapy, I don't know how much time we have, but patient after the mobilization, they come to the center, we collect their stem cell through the leukapheresis, and then we admit the patient for the conditioning with the beam plus ATG, and then they get their transplant, their own stem cell, and then they admit to they remain in the hospital for between 2 to 4 weeks, depends on how quickly the white blood cells repopulate again. They get all their antibiotic immunization, everything, and then we monitor them for 6 years. The primary endpoint of this study is the relapse-free survival for 3 years, and there are multiple secondary endpoints as well. So, few words about just symptom management. We should not forget about that. Most of the disease-modifying therapies for prevention, unfortunately, they don't as much as we want, they don't improve the current symptoms. So this is very important to be communicated with the patient. I've seen over and over again when I ask patient, when you saw your last neurologist, why you stop your medication? Says, oh, the medication he or she gave me, my symptoms was not getting better. As a matter of fact, I had some side effects, so I decided to stop. Patient still doesn't understand that we're talking about the prevention. Symptom management in MS is very different. We have to focus on that because that's the reason the patient comes to us. Unfortunately, many of these patients don't even think about how much risk they are dealing with in the future. They're focused on their current symptoms, so we need to address that. We also need to remember this patient might have a lot of other comorbidities, obesity, hypertension, diabetes, which can affect the outcome of the disease. We have to work with their primary care to make sure that we manage other comorbidities and partner with our patient to take part in their health, mental health and physical health, do work on their wellness, smoking, drinking, toxic habit in their lifestyle can, of course, associated with the poor outcome. So we want to make sure that they do whatever they can to improve their health, brain and body health, basically. Sorry if I rush it, and I'm sorry again for the technical problem. I want to thank you for your attention and thank you, all of you, for everything you're doing for our MS patient. I appreciate it.
Thank you very much, Dr. Zabiti, for your very nice and comprehensive lecture. Actually, that was one of the best overview of multiple sclerosis I have ever heard. Thank you very much. We had received plenty of questions, so I start with the first one from Dr. Navardi. Dr. Navardi has asked, and first she has said, thanks for your nice lecture. If we want to choose between cladribine or anti-CD20 therapy, if there is an advice to start with cladribine and then go on then go on anti-CD20, or which one do you prefer to start first?
So generally, I'm more comfortable with the anti-CD20. We had a lot of more experience with the anti-CD20, but maybe I missed the question about what was the previous medication that patient, what medication was taking before we switched to these two drugs.
Okay.
So that's also a consideration basically, but generally I prefer the CD20 therapies.
First, okay. Another question from one of our colleagues: in decrease in brain reserve or progression without acute attack in patient on high potency drug, what is the next step? It means that if you have a patient, no relapse and no relapse, but it's on high efficacy drug and you have progression, what will you do?
Which unfortunately, this is exactly our challenges. Again, I think the question is about that smoldering or chronic active MS patients that they have brain atrophy and they don't have any new disease activity. None of our current disease modifying therapy honestly address that issue. In our center, thankfully, we are part of those BTKI study, whether they have relapsing MS or primary progressive MS. I enroll them to the study sometimes, but with the current treatment, unfortunately, that's a limitation. I wanna draw everybody's attention when I talk about the smoldering MS, this compartmentalized inflammation. One of the best available treatment, as we discussed, are monoclonal antibody. They don't even get to the central nervous system with the blood-brain barrier. And even a small molecule such as S1P modulator, we really don't know if we are targeting the compartmentalized immune system. We are mostly focused on that. So the answer is that unfortunately, we don't have very good treatment yet for the patients that they have brain atrophy.
Thank you very much. The next question is from Dr. Nahayati from Mashhad. What's your approach in treatment of young under 40 years ambulatory progressive MS patient? EDSS is 5 without MRI activity under treatment of first or second line disease modifying treatment. Do you escalate this patient?
I think these are all questions about the progressive MS. As I said, no effective therapy. I would make sure that they are, I think more, when I keep repeating myself, but based on our experience for both relapsing and progressive MS, it seems that B-cell therapy has the best result as of now. I just want to make sure they are on the B-cell therapy.
Okay, thank you. Question from Dr. Baghbanian. What is your treatment or management approach for wearing of phenomenon in patients receiving anti-CD20 therapies?
And these are all very questions and are daily challenges. If the insurance allow me, sometimes I move their next therapy a little bit earlier, but here it's not always easy, honestly. Insurance usually here very restricted about every 6 months interval. So basically nothing. We don't have as much good options. I really don't know, these are just hypothetical, but when I mentioned about the new generation of the B-cell therapy, we don't know, maybe by more effective depleting the B-cell, because sometimes those wear-off effect might be associated with the repopulation of the B-cell. It's not very clear, but it might be some association there. So maybe with the newer generation of B-cell therapy, we have less of the wear-off effect.
One approach I do actually, Aram, I can share with you and see if the patient is on rituximab, not on Ocrevus or on rituximab. If I want to give the patient 1 gram every 6 months, I divide it into 2 500 milligrams every 3 months. And sometimes it helps in reducing the wearing of phenomenon. And for ocrelizumab, sometimes if the insurance, as you said, I go to actually ocrelizumab every 5 months or 5 months and a half. So sometimes the wearing of phenomenon gets less. And with rituximab, I have this approach sometimes, and it works.
That is correct. And there are ongoing trial on the higher dose of ocrelizumab. We know that that 600 milligram is not the best treatment for everyone. So there is a focus on the personalized medicine to understand who responds to what dose of the medication. But I'm glad that you have that option of changing the dose. Here, unfortunately, we are very limited on that.
Thank you very much. Next question from Dr. Nahayati, which is also a challenge also for me. Another challenging question: what is your suggestion in a patient with inflammatory bowel disease and multiple sclerosis and the treatment of Tysabri after 2 years of therapy with positive JCV index above 2? So it means that you cannot go on B-cell therapy because the patient is already have inflammatory bowel disease, and sometimes we have case reports of inflammatory bowel disease following B-cell therapy. What is your approach?
I have only one patient with that here there is actually another anti-alpha 4 integrin inhibitor. So considered as a newer Tysabri, but only indicated because that molecule only bound to the GI without risk of PML, which was very fascinating. I didn't know about that until the GI doctor told me. Said we don't use Tysabri for the GI, but we have a newer molecule that is not even associated with the PML. They don't have any, they don't bond, they don't cause that problem in the blood-brain barrier. So there's no risk of PML with the new molecule for the IBD. And they use that, and the GI doctor told me that you can use any other MS drug that you want. So we put it in the two different disease model treatment, immune therapy, basically for IBD and for MS. And just to mention that Zeposia or ozanimod also is approved here for the ulcerative colitis, not for Crohn, but for ulcerative colitis. Maybe that would be a consideration to change it to ozanimod or Zeposia if it's available.
Unfortunately, we don't have ozanimod at the moment available in our country, in Iran, but I think it will be available in few months. One of the major questions you talked about actually high efficacy therapy, early high efficacy therapy. The question is, which patient do you use high efficacy therapy from the beginning? I mean, if you see every patient, for example, one patient with one optic neuritis and 3, for example, MRI, but the patient is male, have some risk factors, OCB is positive, one is spinal cord lesion. Do you actually choose high efficacy therapy for this patient, or you prefer to go to medium or low efficacy first?
Well, those some of the poor prognosis factors you mentioned, certainly that's a big drive for me to choose them. But I have to tell you honestly, I have a low threshold to do high efficacy therapy for any reason. Again, although most patients, they are very worried about some of the rare side effects of this drug, but as a matter of fact, there are data to show they are not too different. If they are in the right treatment setting. So let's say in United States, I see that sometimes that if the provider are not familiar with type of the side effect of the drug, so patient, yes, they are at risk, but in the MS center, we know how to monitor them for the safety of the drug. So I generally have a very low threshold with a highly effective therapy. We use a lot of monoclonal antibody as a first line. I mean, one of the easiest kind of way of starting with the monoclonal antibody, just checking the JCV. If JCV is negative, natalizumab still is one of the not only most effective therapy. As a matter of fact, if there is no risk of PML in the JCV negative patient, really it's one of the safest drug. Really don't have as much other side effect. So we still use a lot of natalizumab. If they are positive, then we put them on the B-cell therapy. I use a lot of the highly effective therapy early on, except again, for the patient that they don't want to do infusion, they don't have access to the infusion, they don't want to do injection. So then I put them on the oral drug, but many of our patients are start with the highly effective monoclonal antibody as a first line.
My next question, actually, this is my own question. In Iran, we monitor the patient with MRI, with new T2 lesion, gut-enhancing lesion, but not with the atrophy, not with cognitive assessment at the moment in clinical practice, and also not with neurofilament. When you see a patient for 10 years on interferon, but no new T2 lesion. But you heard a lot of data about high efficacy therapy. You still have, you still have the feeling that you are not doing the best for this patient. The patient is on interferon, for example, on Sinovex or on Rebif for 10 years. You have only no new T2 lesion, but you don't measure atrophy, you don't get cognitive, and you have, for example, rituximab or ocrelizumab, or in near future cladribine. Without any new T2 lesion or any relapse, do you consider to change this patient into high efficacy drug?
I do, but if you don't, you're not making any, you're scientifically, we don't have a proof. That's one of the reasons volumetric MRI, neurofilament, none of them is approved by FDA yet as a criteria for switching the medication because of all the limitation. Even in our center that we do volumetric MRI, we check a lot of this biomarker. I have to say that I've seen a lot of inconsistency, even with my limited experience, because these techniques, unfortunately, are limited. But for me, it's an excuse. As I mentioned earlier, I look for those excuses. That's exactly what you described. I said, okay, let me, if I just want to make sure that the patient is comfortable, and I tell them that allow me to put you on the highly effective therapy. It's my responsibility to monitor you for the safety. You're the one that you're taking that risk, but I'm more familiar and comfortable with this drug for many years. I can monitor you for the safety. What I cannot allow to happen in my practice, as you mentioned, is if this patient become cognitively disabled, they continue to have brain atrophy, and then I have no option. Even none of this newer treatment that is in the horizon, they are not doing a good job in the neuro restoration or neuro repair, right? So that's my focus. And as long as most of the patients actually get on board very easily, I said, let me take some risk. We're gonna take some risk, but let's get you on the more effective therapy or switch your therapy in hope that even if this brain atrophy, even if this neurofilament is not very accurate, I wanna make sure that we do whatever we could at this time before we regret it in the next few years.
Thank you very much. And the last question is from Dr. Baghbanian. And this is about de-escalation and treatment discontinuation after the age of 60. What is your opinion?
Sure. As I presented, because I moved so fast on some of this slide, let me put it up again so you can become familiar with some of this data. So they actually looking at that. So for this DISCO MS, they look at the age of 55, even earlier than 60. 60 was, I think there was a smaller study in the Cleveland Clinic, but this is a much larger multi-center clinical trial. In my practice, to answer to your question, I have this conversation with a lot of my patients. After being 10 years at UC, I have a lot of those patients that I'm confident. Again, if they are new patients in my practice, I don't even start that conversation because it gets very complicated. But if I have a patient for 10 years, I'm monitoring and getting the MRI, I'm comfortable and saying them that I don't see any disease activity. Let's give it a try. Here we call it holiday therapy. Let's just take a holiday, stop the disease modifying therapy. We're not going to let you go. Then that's the key. We're not going to have them, oh, go home and just call me if you have a relapse. We're going to continue to have even more visit, more follow-up MRI to make sure they're off the, after stopping the disease modifying therapy, they're still stable. But yes, I do it a lot for patients that they have that type of a stability. I stop the disease modifying therapy. Again, first, we don't know if they need it because as you saw, the risk of the neuroinflammatory phase of the disease is reduced. And that's the only way, that's the only mechanism of action of this drug. They're not gonna do the neuro repair or anything. So if the risk of relapse or MRI activity is low, I stop it. And then the risk of the side effect increase by their age. So for all those reasons, this old patient, they need to get vaccination. During the COVID, I stopped a lot of this patient just because, I mean, even on the B-cell therapy, I said, let's take a break, see what happened. So this is some ongoing conversation with some of my patients that I can trust them that they come back for the monitoring of the medication.
For the patients who are after the age of 50 and they have started fingolimod, for example, from the age of 45 and 10 years on fingolimod, do you prefer to, how is your exit strategy because of the chance of rebound
Yes.
or relapse activity? Do you prefer to give them a shot of anti-B cell therapy and then stop the medication? Or do you go on the escalation, for example, on interferon and then discontinue the medication? Because we have some patients after the age of, for example, 60, and we have started fingolimod 10 years ago, and the patient have been stable on that, and now we are afraid of some side effect and we want to de-escalate.
All of the approaches that you said, I think it's reasonable to do B-cell therapy, interferon, Aubagio. I use a lot of teriflunomide in my elderly patient. Again, I'm not worried about the risk of pregnancy. I'm not worried about the opportunity. We haven't seen any opportunistic infection with the teriflunomide. So these are all consideration. One of my actually fellows that he's actually has a large MS center. He published, Dr. Obey, that published a lot of data on switching Gilenya to cladribine. So as I mentioned, many of my colleagues are now using mavenclad as an exit strategy. They give that 2 rounds of the mavenclad and then they stop it. Of course, there was some concern about, oh, patient on Gilenya is already lymphopenic. Now you want to put them on the cladribine. But based on his cohort, they didn't see any increased risk of infection or opportunistic infection or anything. So basically, most of those approaches are, I think, reasonable, but you're right. The risk of rebound is so important that we need to have that type of exit strategy.
Thank you very much indeed. And that was a really fruitful meeting, answering our questions, discussing some difficult issues and your excellent overview of MS treatment. I would very much like again to thank you and also thank all participants and also thank Dr. Yaghmai and the staff at Tehran University of Medical Sciences that gave us this opportunity to be with each other. I wanted to ask you to have other sessions with you, Dr. Zabiti, because that was so fruitful for us. And I think this discussion will help the patient in Iran actually, and we will have better skills of treatment for this patient. Thank you very much. And Dr. Yaghmai, if you have anything to say, we are waiting for that, and then we can close the session.
Thank you all. Thank you for the opportunity.
Dr. Yaghmai, if you are. Okay, if not, thank you very much. Thank you. Thanks all.
Khuda Hafiz.
Khuda Hafiz. Khuda Hafiz.